All right, everybody, here we go. Let's talk a little bit about levels of evidence. And in this lecture, we're going to talk specifically about themes in evidence ratings, and then we'll do the other one in another lecture. So there are four major themes that we're going to talk about. So what's really important to researchers when it comes to what gets rated higher or lower? Number one, independent confirmation and confirming evidence. Number two, experimental control. Number three, avoidance of subjectivity and bias. And number four, relevance and feasibility. So number one, independent confirmation and confirming evidence. So the highest evidence ranking goes to well-designed systematic reviews and meta-analyses. So a systematic review is a study that has systematically summarized results across a number of scientifically rigorous studies. So we're going to have a system where we're going to search for every article published between 1970 and 2020. It needs to meet this criteria. We're going to search in Google Scholar, in PubMed, in all these different places. We're going to list every article we found, and then we're going to only choose articles that meet like this certain criteria. All right, so that's what a systematic review is. A meta-analysis is an analysis of analyses. So let's say there were 9 articles published, all on the same kind of therapy that gave their data. Well, we're going to, in a meta-analysis, we're going to combine all of that data as if it was one study and reanalyze the data to get, what's the total analysis. So a meta-analysis is an analysis of analyses. Number two, we're looking at experimental control. So evidence from studies that are controlled and employ prospective designs, so patients are recruited and assigned to specific designs prior to the study, are weighted more highly than retrospective studies. Right, so why would that be? Why is that important? Well, in a prospective study, right, you can choose, when you're going to do the study, you can choose, who's going to be counting whatever needs to be counted, how they're going to count, what they're going to do, how it's going to be done. Whereas if it's done in a retrospective way, right, then all of a sudden it gets much harder to do it. Nope, not that one. So this is the one we want to go to. So this is an article from Scott Yaris and colleagues in 1998, evaluating stuttering in young children. And what they did was to go through and describe relationships between speech, language, and behaviors on evaluations that had already been done. All right, so subjects were 100 children who appeared to be representative of children that clinicians are likely to evaluate. Analyses were based on a retrospective examination of detailed diagnostic records prepared during the diagnostic evaluation. So, all right, they're looking at moments of stuttering and speech, counts, language, related behaviors, right? They can't go back and watch the videos because there are no videos. There's only what was done during those evaluations. And then, right, are we sure that every clinician was trained in how to count a moment of stuttering versus a moment of normal disfluency, right? So it's because it's retrospective, it's not the data was collected before the study. So you're going back and looking at older data. You don't have the same kind of control. You don't have the same knowledge that, things were counted a certain way, things were done a certain way. So that's why prospective designs, ones that you design, and then collect the data a certain way, are going to be weighted much more highly. And then also, right, random assignment is going to be weighted highly. So those studies where participants were randomly assigned into groups and not placed in groups either by the researcher or by the clients themselves are going to be the most valued, because it reduces the bias of who got put into what groups. We might talk later about how, there are some reasons why you might want to select which clients go into what, so that you can match for certain, maybe you want to match for gender, or you want to match for different things. You could still do some of that randomly, but we want to be so. But overall, because of the reduction of bias, completely random assignment is weighted the highest. And then, right, what do we mean by random assignment? So our definition of random assignment is that every participant has an equal opportunity to go into either group. So if I divide 20 preschoolers who stutter up into two groups, 10 kids who stutter get therapy A, 10 kids who stutter get therapy B, right? We're going to assign our 20 kids numbers, and we're going to, have the computer randomly pick numbers to decide which person goes where, right? So that every person had an equal chance of being in either group. So that's random assignment. All right. Number 3, avoidance of subjectivity and bias. So things like blinding, concealment, or masking of investigators, and if possible, clients, right? So when you do, when someone does a drug study, right, they can do a double blind study where the patient doesn't know if they're getting the real medicine or a placebo, a sugar pill, and the doctor prescribing it doesn't know whether the patient's getting the real medicine or a sugar pill. Obviously, we can't do that. Like if we're giving therapy, right, we need to know that we're giving therapy. We need to know the therapy we're giving, and the client is going to know whether they're getting therapy or not. However, what we can do, right, is we can record the pre-test assessment and the post-test assessment. We can then have speech therapists watch videos. They're not going to know if it's a pre-test. They're not going to know if they're watching a post-test. And they're not going to know which group the clients were in, if they're getting therapy A or therapy B. They don't know if it was before therapy or after therapy. They're just going to do their counting or do their assessment, whatever it was. Right. So in that way, we can do blinding and concealment of the investigators. And a big reason that, right, is that belief in the value of one's efforts is a prerequisite to clinical practice, right? That if you're a therapist, you're going to really believe that your clients are making a change, because that's what a good therapist is. A good therapist believes that clients can change. A good therapist believes that clients are changing, and that things are getting better. So that you shouldn't really be the one doing the pre and post assessment, because you're going to naturally think they're doing better, because that's what a good therapist does, but that's not what a good researcher does. So we got to be careful to separate those two things. And then the requirement that outcomes be reported for every patient originally enrolled in the study, right? There used to be a lot of stuttering research out of Australia, and it was that, clients were 100% fluent after the therapy. And what they would do is they would teach clients to talk like that. Now, what they didn't say was that half the clients dropped out of therapy because they didn't want to talk like that, and they preferred to stutter rather than talk like that. So, you got to give information about how many people actually completed the study, when people dropped out, why they dropped out, and things like that, right? Just because, all right, 100% of the people who, completed it are fluent, number one, most people dropped out, and number two, not even really sure that's fluency. So you just have to be really open about people in your study. And then last is just relevance and feasibility, right? We want clients to be typical. What's hard is that sometimes you'll get research from a university and it's like, wow, these kids who stutter, all these preschoolers who stutter have really high language skills. Well, it turns out that, 3/4 of the kids who stuttered, their parents were faculty members at the university who all have really high language skills. And so those are not typical kids. We need to have typical clients. We want to have clients as typical to the average kids as possible, looking at gender, looking at ethnicity, looking at lots of important factors, right? So what's our typical kid? And we want to try to get that if we can. And then last is just feasibility or applicability is high when the independent variable being used is one that could reasonably be applied or used in real world settings. They started doing things like using virtual reality for kids who stutter back in the early 2000s. And, it was kind of cool, but, it had no feasibility. Like, a school speech therapist wasn't going to go into her principal and ask for a $50,000 virtual reality machine, right? That's not. She would have gotten laughed out of the office, right? So, is it feasible? Is it real? Could it actually be used? Or is it just kind of a fantasy? Not that that's bad, right? Because now virtual reality is becoming more of a possibility, so that research was important, but at the time it didn't have, particular relevance. All right, and we're going to stop here, and then we're going to talk about levels of evidence later.